consultant gynecologist at Concept Lahore. And our panelists, Dr. Fouzia Monoo, Dr. Razia, and I would like to invite Dr. Samira, to start on the session on first trimester management and luteal support. Thank you very much. Please welcome.
Assalamu alaikum. So my topic is first trimester management post IVF or post ART. And today let me talk some points which we already maybe know, and there are some points in some studies which are very interesting to know. So as we know, in a first trimester we are doing pregnancy monitoring. At time of expected but missed menstruation, the beta HCG level is around 100 international unit, and the levels influenced by many factors, including multiple pregnancy, so it will be higher at this gestation in multiple pregnancy. The maximum is 100,000 international unit by 8 to 10 weeks, and as we all know, levels decrease and remain steady at 10 to 20,000 around 18 to 20 weeks. The urinary SCG home test can detect 25 to 100 international units, so they can be false negative. According to the gestational age, if you want to take the picture, this is available online, how much beta HCG at what will be the ultrasound findings. So there are few terms that we use in first trimester. The first term that we use is biochemical pregnancy, which is positive serum or urine SCG, but a miscarriage occurred prior to ultrasound confirmation. So this is biochemical pregnancy. SCG levels are lower than normal. Blighted ovum, we don't use this term anymore, but it is anembryonic gestation. There is a gestational sac without embryonic presence. And SCG levels may decrease or have abnormal rise and then decrease. Now the clinical pregnancy. It is diagnosed once a pregnancy is confirmed by ultrasound. And SCG levels continue to rise until 8 to 10 weeks of gestation, and ongoing pregnancy is the current viable pregnancy. Now singleton pregnancy, it's mostly uncomplicated, but there is increased risk of perinatal and maternal complications, certain generic risk compared with the spontaneous conceptions. And infants born after ART are at increased risk for adverse health outcome as well. Multiple pregnancies. The talk of multiple pregnancy is next, but I have like 2 slides related to multiple pregnancy. ART conceived twins may do better actually than non-ART twins, but all multiples as a general rule has increased risk compared with singletons. So some figures. The incidence of twins is spontaneous is 1.25%, with clomiphene citrate is 5 to 10%, with gonadotrophins 15 to 20%, and with IVF it's 15 to 33%, and mostly they are monozygotics. The higher order multiples, which is triplet or more than triplet, in IVF is 2%. Since we are having single embryo transfer, sometimes we are doing 2 embryo transfer, but it can happen that a month ago I transferred 2 embryos and then it turned out to be triplet. So you can always find triplets. So fresh embryos from known donor oocytes, it's according to the maternal age. The percentage of live birth with twins, it differs with the maternal age. At less than 35 to 37 years of age, at 38 to 40 and more than 40, it is decreasing for sure. What are the complications that can happen with multiple gestation? Preterm labor, twins 60% will deliver before 37 weeks, triplet more than 93% before 37 weeks. Hypertensive disorders can happen. Twins have double the rate of singletons. Monozygotic twins, the incidence is higher with ART, and 2/3 of them are monochronic, which are at higher risk of all the risk twin-to-twin transfusion syndromes. Especially infant mortality is 5 times higher in twins. And in twins, there is 12 to 15% of neonatal death. The maternal fetal specialist referral should be done for high order multiples. How to prevent? Monitoring estradiol and follicle development, and maybe cycle cancellation, or and conversion to IVF cycles if you are doing IUI, single embryo transfers, multifetal reduction. It can be triplets to twins, but usually we don't do it. Mortality and morbidity will be decreased if we reduce triplet to twin, but it leads to 6% miscarriages of all fetuses, which might not be acceptable for the woman, and all risk of multiple gestations will not be eliminated, and there is psychological sequences. If you reduce and one of them will be having some defects, then it can be a psychological sequence. Spontaneous miscarriages in first trimester, it can happen. Generally, it's 15.8%, but there is no difference in rate between general population and patients undergoing fresh cycle. Age is strongly associated with the rate of spontaneous miscarriage. What can happen in IVF pregnancies, heterotropic, ectopics? Now, IVF associated with 2.2% risk of ectopic pregnancy compared with 2%, and the incidence of heterotropic pregnancy is also higher. Hyperemesis gravidarum, especially in multiple gestations. Now come to medication. It's best to verify the safety of all medication used, including over-the-counter and prescription drugs in first trimester when organogenesis is occurring. Examples, retinoids, phenytoin, warfarin, non-steroidal anti-inflammatory should be avoided, especially in third trimester. Now, certain medications for chronic conditions should not be abruptly discontinued, and they should be changed to safer alternatives. The patient should be referred to their physician, like anti-epileptic drugs, and patients who are having mental disorders for bipolar disorder and other psychiatric disorders. Let's talk about metformin. Yesterday there was an interesting talk about metabolic syndrome and PCO and the use of metformin. I found it in Journal of Therapeutic Advances in Endocrinology and Metabolism 2010, the role of metformin in management of PCO. So it is used for obese and ovulatory women with PCO and insulin resistance. A recent Cochrane review concluded adding metformin to IVF protocol has no impact on pregnancy or live birth rates, but it decreases the risk of ovarian hyperstimulation syndrome. A small study was reported to have improved oocyte quality in antagonist protocol, but again, it's a small study. The risk of miscarriage. Observational studies showed beneficial effect, but 2 RCTs and a meta-analysis showed no beneficial effect on miscarriage rate. So either continuing metformin is decreasing, it has impact on miscarriage rate. Is it decreasing? Initially, observational studies showed beneficial effect, but recently meta-analysis showed no benefit. Effect on GDM. An early pilot study suggested continuation in PCO patients through pregnancy reduced the risk of GDM among PCO women. And HAPO study group also concluded the same, but it's not an RCT. So there is evidence, but it's not a strong evidence. There is no harm is found on taking metformin in pregnancy, and available evidence regarding GDM prevention is encouraging. So after listening to all, I want to hear from the audience, if the patient of PCO, you are doing IVF for her, are you going to continue, and she's already on metformin, are you going to continue metformin? Yes. Okay. Until what time? First trimester, or you want to prevent GDM? Oh, yeah. The same answer. Okay. So at least first trimester you will continue. This is what we are worried about. Yeah. So regarding myo-inositol is an insulin sensitizer which improves number of retrieved oocytes. So this is interesting to know about myo-inositol because there is a growing evidence of myo-inositol in PCO patients going for IVF. Myoinositol is an insulin sensitizer which improves the number of retrieved oocytes, oocyte quality, and embryo quality in women with PCO undergoing ART. But further research is needed for effect on live birth rate. We don't know about the live birth rate, but it improves the quality. So there is an evidence about myoinositol, and I found it in the International Journal of Endocrinology, volume 2016, about the evidence of myoinositol. Dr. Fouzia, do you have any experience in using myoinositol in PCO patients going for ART?
So I think it should be used.
So the research until now is encouraging, and there is no harmful effect found also. So you can decide to use it. So you can find the dietary guidance from online. If you want to take a picture, you can. Just additional 300 calories more with multiples. Multivitamins, as we all know, 4 milligram for if the patient has neural tube defect. An obese PCO should be given 5 milligram of folic acid. Fruits and vegetables, carbohydrate, protein, fats, anyway. So this chart also can be found in singleton pregnancy and twin pregnancy. What is the difference according to the BMI of the patient? How much should be the total weight range gain? So the prenatal screening and diagnosis. As we all know, all women should be offered both screening and diagnostic testing regardless of age. They should understand the benefits and limitations. There is first trimester screening and there is second trimester screening. In first trimester screening, for Down syndrome, SCG is high and PAP-A is low, but in trisomy 18, both are low. We can check knuckle translucency, fetal nasal bone. What are the options for positive first trimester screening? Either chronic villus sampling can be done around 11 weeks, and later on at 15 weeks amniocentesis can be done. Other conditions associated with high and knuckle translucency. So a patient who has high fetal NT can have congenital heart defects and Mendelian disorders like Noonan syndrome, skeletal dysplasias, and Dye-George syndrome. In second trimester screening, like as we can see in Down syndrome, there are 4 proteins that we are checking in second trimester screening is alpha-fetoprotein, unconjugated estriol, SCG, and inhibin A. In Down syndrome, alpha-fetoprotein is low, only SCG is high, and trisomy 18, and there is something about open neural tube defects. As we all know, alpha-fetoprotein is high, and in twins and in IUFDs. What are the other causes for abnormal screening result? For example, if you find elevated alpha-fetoprotein, it can be abdominal wall defect, fetal renal abnormalities, sacrococcygeal teratoma, cystic hygroma, adverse pregnancy outcome. And decreased estriol is not only in Down syndrome, but it can be in congenital adrenal hyperplasia. And elevated SCG is not only in Down syndrome, it can show adverse pregnancy outcome. So what is NIPT? It is non-invasive prenatal testing. It's a cell-free fetal DNA to test for aneuploidy, and it's non-invasive and highly sensitive and specific for trisomy 21, 18, and 13. And nowadays, the physicians are reverting to NIPT because it's highly sensitive, almost 100%. In multiple pregnancies, it has lower sensitivity. It decreases the invasive testing by more than 50%, but it's a bit expensive. It can also reveal maternal cancers. This is in Journal of Obstetrician and Gynecologists in 2017 when they talk about NIPT testing. You can check from 10 weeks onward, 10 weeks of pregnancy. So in level 2 ultrasound anomaly scan, what are the birth defects? In Down syndrome, you can detect atrioventricular canal defect, trisomy 18, omphalocele, diaphragmatic hernia, and the soft markers like in Down syndrome, echogenic bowel, short limbs, in trisomy 18, choroid plexus cyst. We have chronic villus sampling, which we do around 11 weeks. It can be transcervical, transabdominal, and we can check it for karyotyping. Amniocentesis is around 15 weeks, and we are doing it through usually abdominal route, and we do karyotyping with it, with the fetal cells obtained. What are the possible complications of chronic villus sampling and amniocentesis? It can be bleeding, contractions, infections, amniotic fluid leakage. Fetal complication can be miscarriages, limb defects, and placental mosaics. What are the referral for obstetric care? It occurs after viable intrauterine pregnancy has been confirmed. Fetal-maternal specialists, we should refer the patients of high-order multiples, maternal medical or surgical disorders, and high-risk pregnancies. Now let's talk about luteal support. Corpus luteum is primary source of progesterone until 10 weeks of gestation. And in infertility treatment, corpus luteum is disrupted during oocyte retrieval. GnRH analogs continue to suppress LH production. That's why luteal support is important. Progesterone supplementation is recommended after IVF until 10 weeks of pregnancy, but we give until 12 weeks. This is the ASHRAE guideline 2019, February 2019. It talks about luteal phase support. So there is an evidence in a Cochrane meta-analysis that progesterone is recommended for luteal phase support, and how much progesterone in what way, like intramuscular, vaginal, or oral, we can give. Let's talk about starting of progesterone should be in the window between the evening of the day of oocyte retrieval. This is what we do. We give the patient progesterone in the evening of the oocyte retrieval, and it should be administered at least until the day of pregnancy test. Dihydrogesterone, as Prof. Arshad was talking yesterday, is probably recommended for luteal phase support. Its efficacy and safety are equal to progesterone, so it is in the ASHRAE guideline 2019. There are two trials he mentioned yesterday, Lotus 1, Lotus 2, which are phase 3 randomized controlled trial, which comparing the efficacy, safety, and tolerability of oral dihydrogesterone versus micronized vaginal progesterone for luteal support in IVF. As you can see in the graph, there is an increase. The orange is micronized vaginal progesterone, the blue is oral dihydrogesterone. So there is some increased incidence of ongoing pregnancy rate and live birth rate, although there is a small increase, but it shows good results. So Lotus 1 was an international phase 3 RCT, and the results as I show above. So oral dihydrogesterone is also well tolerated. It is oral and it has similar safety profile to micronized vaginal progesterone. So the results presented is supported by the Cochrane review and meta-analysis, and it shows paradigm shift towards oral dihydrogesterone in fresh cycles of IVF. These are my references. Thank you very much.
Thank you very much, Dr. Samira. Now I would like to welcome Dr. Uzma Akram. Dr. Uzma Akram is consultant gynecologist and fertility specialist at Concept Karachi. After her MRCOG, she has participated and attended several workshops and seminars in UK and Pakistan. She also has experience of teaching medical students and postgraduate trainees for FCPS Part 2. And currently she is working as consultant gynecologist and fertility expert at CFC Karachi. She will share the management of multiple pregnancy. Welcome.
Assalamu alaikum everyone, good morning. I would be presenting management of multiple pregnancy today, and some of it has already been discussed by Dr. Samira. And we know that multiple pregnancy is a high-risk situation because of its inherent risk to mother and fetus, and twin or multiple gestations are gaining importance worldwide because of its rising incidence. And optimal care is required for reducing the morbidities associated with it. And why we are discussing it? Because the incidence has increased due to the increased use of ovulation induction drugs and frequent transfer of multiple embryos in ART procedures. While multiple births comprise only 3% of live births, nearly half are conceived with infertility treatment. And here we can see that how the infertility treatment is affecting the rate of multiple gestations, which are already been shown by Dr. Samira as well, that IVF itself increases the rate of twins to 15 to 30%, whereas higher order multiples increase to 2%. Considering that it is a high-risk situation, multiple gestation is suspected or identified, ultrasound examination should be done at the earliest. And first trimester ultrasound between 10 to 13 plus 6 weeks is a highly accurate and reliable method of diagnosing multiple gestation and chorionicity. And early diagnosis of chorionicity is essential as it carries its own risks. And now what are the risks associated with multiple gestation? We can see that there is an increased maternal, fetal, and neonatal morbidity, but the risk increases as the number of fetuses increase, whereas ART treatment itself is not found to be a risk factor for adverse perinatal outcome, but it has itself increased the rate of multiple births. Whereas monochorionic twins are at a higher risk of fetal loss and morbidity, and monochorionicity has also increased because of ART, especially when embryo transfer is done at day 5. Preterm birth, infant mortality, ovarian hyperstimulation, gestational hypertension, and early severe preeclampsia and HELLP syndrome are some of the major risk factors affecting the multiple gestations. This has already been shown that how we can reduce the rate of multiple gestations in ART treatment cycles by using single embryo transfer or canceling the cycle by monitoring estradiol and follicle development in controlled ovarian hyperstimulation cycles. Multifetal reduction has already been discussed that we can perform it between 10 to 13 weeks, but it carries its own risks, like 6% loss of the ongoing pregnancy as well. Now, how we are going to manage the multiple gestation and its complications? As you know, the major complication is preterm birth. And it is important to note that as the number of fetuses they are increasing, the gestational age is decreasing, and therefore, at 32 weeks, only 1.6% of singleton deliveries they occur, but 12.1% of twins and 36% triplets and 75% of quadruplets they may deliver before 32 weeks. Similarly, before 37 weeks, 11% of singletons deliver, but 80% of twins, 92% of triplets, and 94% of quadruplets they can deliver before 37 weeks of gestation. Screening by cervical length for detection of preterm labor can be done and should be offered between 18 to 24 weeks, but we have to understand and counsel the women that even if there is an increased risk of preterm birth with twins, and it is accurately identified, there is no effective preventive intervention, including bed rest, progesterone, cervical cerclage, or tocolytic medications. What is effective is steroids, which should be given if delivery is expected before 34 weeks of gestation, or if cesarean section is planned before 37 weeks of gestation. Repeat steroids in cases of threatened preterm birth should be based on individual circumstances, and it should not be used in an untargeted routine manner. The major complications associated with monozygotic multiples are unique and they're difficult to treat as well. And monozygotic twinning is a random event in spontaneous conception occurring at a rate of about 1 in 250 live births, but incidence is increasing in pregnancies resulting from ART treatment. And we can see fetal structural abnormalities, twin-twin transfusion syndrome, twin anemia polycythemia sequence, twin reversed arterial perfusion, inter-twin growth discordance, or there could be a single fetal demise. Monozygotic twins are 2 to 3 times more likely to be affected by fetal structural abnormalities, and expert fetal anomalies scan between 18 and 20 weeks of gestation, including fetal echocardiography, is essential in every case of monozygotic twins. Twin-twin transfusion syndrome also complicates 15% of monochorionic pregnancies because they share the vascular anastomosis. Therefore, screening by ultrasound should start as early as from 16 weeks of gestation. Where there is unequal hemodynamic and amniotic fluid balance, there is risk of twin-twin transfusion syndrome. And once it is diagnosed, it should be staged using Quintero system and umbilical artery Doppler velocities, and it is essential to be referred to a fetal medicine unit. Wherever it is possible, and it is presenting before 26 weeks of gestation, it should be treated by selective laser photocoagulation of placental anastomosis, and delivery should be conducted by 34 weeks of gestation. Twin anemia polycythemia sequence complicates those pregnancies which have been treated for twin-twin transfusion syndrome, but it can occur as such in monochorionic pregnancies. The recipient twin is at risk for successively increasing blood count and donor for progressive blood loss. Doppler studies using middle cerebral artery peak systolic velocity is done for diagnosing and must be managed in a fetal medicine unit. Inter-twin growth discordance means that a 15 to 25% reduction in the estimated fetal weight of the smallest fetus compared to the largest. If anticipated difference of 18% or more between co-twin weights in both dichorionic and monochorionic gestations, intensive fetal monitoring and use of umbilical artery Doppler is required, and all such cases also need referral to the fetal medicine unit. Now, single fetus demise in multiple gestation is a unique situation, and it's challenging to manage. It can happen in the form of vanishing twin phenomena, in which one multiple spontaneously disappears before 12 weeks, and it is common occurrence, particularly in IVF cycles with transfer of more than one embryo. There is an increased risk of such happening with increased gestational sacs and maternal age. Vaginal bleeding is not unusual, but there is no effect on surviving fetuses. And we can see how the increase in the number of fetuses increases the risk of loss spontaneous before 12 weeks of gestation. In singletons, it is only 19%, but twins has 36%, triplets 53%, and quadruplets, it can be as high as 63%. In utero demise in second and third trimester is challenging to manage, but it can happen more commonly in monochorionic than dichorionic pregnancies. In monochorionic gestation, the risk of surviving co-twin demise is as high as 12%. And severe neurological injuries surviving twin is up to 30%. All such cases need to be referred and assessed in fetal medicine unit. The monitoring of the surviving twin with using middle cerebral artery Doppler for fetal anemia and MRI of fetal brain may be performed to assess the neurological morbidity so that the earlier delivery of the surviving twin can be planned. But in all monochorionic twins, the risk of imminent demise must be balanced against the risk of prematurity with iatrogenic delivery. Considering that this is a high-risk situation, multiple gestations, all antenatal and perinatal care should be hospital-based, and it must be delivered by a team that includes obstetrician, sonologist, and neonatologist who are all experienced in managing multiple gestations. Ultrasound surveillance and early identification of complications is key to reduce the adverse outcome in all multiple gestations. For uncomplicated monochorionic twin pregnancy, the frequency of antenatal visits should be every 2 weeks from 16 weeks of gestation onwards, For early detection of twin-twin transfusion syndrome, ultrasound should be performed in every visit. For uncomplicated dichorionic twin gestation, antenatal visits should be every 4 weeks from 24 weeks with ultrasound on every visit until delivery. Timing and mode of delivery is very important in multiple gestations, and planned birth with closed fetal surveillance reduces the perinatal morbidity and should be offered to the mothers. The mode of twin delivery should be considered on the basis of individual case characteristics to include comorbidity, gestational age, and women's preference. In uncomplicated dichorionic diamniotic twins, we should not go beyond 36 plus 6 days of gestational age, as it increases the risk of fetal death. Vaginal delivery should be offered if the leading twin is cephalic. In monochorionic diamniotic fetuses, one should not go beyond 36 plus 6 days of gestational age. Again, there is an increased risk of fetal death when gestational age is beyond that. In this situation also, vaginal delivery can be offered if the leading twin is cephalic, but rate of cesarean section increases. But in uncomplicated monochorionic and monoamniotic twins, the 32 to 34 weeks is the time of planned delivery and offered by cesarean section. In uncomplicated triplets and gestations, one should not go beyond 35 weeks of gestational age, and cesarean section should be the mode of delivery. So I can conclude that early diagnosis, appropriate assessment, and management is important for multiple pregnancies. ART procedures have increased the incidence of multiple gestations. Therefore, standard guidelines must be followed, and embryo transfer, single embryo transfer in IVF cycles should be encouraged so that we can reduce the risk of multiple gestations, which have increased because of ART treatment. Thank you.
Thank you very much, Dr. Uzma. Any questions from the participants? Mic दीजिएगा please. Table पे. Button on कीजिएगा please.
I wonder if you will still not consider cervical encerclage if there is funneling of the canal, or you find it less than 2.5 centimeter in multiple pregnancies. You did say that there is no evidence, but practically speaking, I've seen, I mean, there's not much
Yes, people
point.
are still doing it, and it is being still done, practice, but the evidence shows that it does not affect the prevention of preterm birth. That's why it is not recommended.
Then what's the point of measuring the canal and checking for the funneling if you're not going to do anything about it?
That's why women who are offered this, they need to be counseled that even if we are doing these measurements, but if we take any, there is no still effective preventive measure, but we can counsel them that yes, you are at a higher risk for having a preterm birth, and she can be prepared, and we are also be prepared that this is what's going to happen with her.
We are talking about very earlier on, like 20 weeks or so. So obviously you want to do everything. I mean, practically speaking, I've seen in UK also being done once they find it funneling or they find it short canal, especially with ICSI and assisted.
And so I will also like to ask the panelists what are their opinion about it.
There is a role for a rescue cerclage in patients at a stage later than 14 weeks, because the routine cerclage we do for cervical incompetence, which is diagnosed on ultrasound scan and the history of the patient, and that's around 14 weeks. But we need to understand that if the dilatation of the cervix is happening because of patient having preterm labor or contractions, then the cerclage is not going to help. So these are, I think, selected cases where without any evidence of preterm contractions, you are noting the shortening of the cervix in your serial scans, and then at a later stage, a rescue cerclage may have a role in selected patients depending on their history and clinical presentation at that time.
So, thank you very much.
Can I
Anything
have-
else to add?
Yes,
Ji.
I'd like to take Kevin's or Graham's, opinion about how they manage their twins, IVF twins. And especially this cerclage issue is very contentious because, evidence says one thing and then we do something else.
I don't do obstetrics currently, but I do get involved in my public sessions with women who are coming in with threatened miscarriage or mid-trimester funneling of the cervix on ultrasound. My experience when they're referred on to my obstetric colleagues is that in twins they don't do cerclage even when there is signs of cervical change. It's regarded as being contraindicated. But they are very keen to do cerclages, far keener in general, far keener to do them than I experienced in the UK, where I've got to say they were largely falling into disuse under nearly all circumstances. So it seems to be one of those cycles of medicine where we go through 180 degrees, we don't do things for years, and then we bring them back again. So I'd have to say at the moment the jury's still out, but it still seems to be the case that in multiple pregnancies it appears to be contraindicated.
Thank you, sir.
Another comment, like Fauzia's talking about the emergency cerclage, from what's written and generally in my own experience as well, because I've done it a couple of times and seen my consultant do it in UK as well. But again, that was in an IVF pregnancy where you're just desperate to do something to stop this from ending up in a mid-trimester abortion. The most you achieve is maybe 1 week or 2 weeks, if you're lucky.
Yeah, that's the whole idea.
But if you do nothing, she's gonna pop straight away.
Yeah, so I mean, you have to balance the risks versus the benefits and see that.
And counsel the woman that you may be doing this as a desperate measure, but it's very unlikely to work. But we all do it. And as far as the twins, cerclage around after 12 weeks. So I got into I'm just sharing my experience if anyone would like to share as well, since we have like 10 minutes for discussion. So this was a lady who had an ICSI pregnancy. I'll sit down. An ICSI pregnancy, and then she miscarried mid-trimester, typical mid-trimester abortion of an incompetent cervix. Previously, she had never been primary infertility, so never been pregnant. Cervix looked fine before. And I think she was 23 weeks and she miscarried. And then she was very upset and then came back she had frozen embryos. And when I examined her doing the dummy embryo transfer in clinic, she had a totally patulous cervix. You could easily put in a finger at the time. And she was referred to me by another gynecologist. So I said that, look, we can do the embryo transfer, but I think you should have a prophylactic cerclage in view of your previous history. And now, so she conceived, and she with twins the second time round with the FET, and her own consultant just refused to do it, that there is no evidence to do cerclage for twins and blah blah blah. And in the end we got two of our consultants, Dr. Setna and I, got into a whole discussion with her that, look, we think clinically this problem exists. Right now she doesn't have it, but we are not 100% sure, but quite sure this will happen again. So we have to do our best. So she said she refused to do it, and she said, okay, if you want to do it, you do it. I'll look after her afterwards, but I will not do the cerclage. So, you know, I did the cerclage and handed it back to her. She went to term. So thank God for that. But I just feel that, you know, we have to listen to each other. There's no one right answer in many cases, and experience does talk. When you have somebody who was far more senior to me, also backing up this strategy, yes, we should be doing it, then I think we should do it. I don't know what Graham and
Thank
Kevin
you, Dr.
think.
Sadia. I'd just like to add that in prophylactic cerclage, obviously you're not going to see if it's twins or not. This is for, so yes, so you do need to do it because it's cervical incompetence, your clinical diagnosis. You'll do it in next pregnancy irrespective of the gestation. I think that was my concept, yes.
Two things as usual from me. Firstly, once she's had a diagnosis of cervical incompetence, I don't think there's any doubt in my mind that I would do a prophylactic cerclage in the next pregnancy. But as Kevin, I haven't done obstetrics now since 2012. Secondly, though, and a criticism, I think, did you put 2 embryos back? Oh, in which case, no criticism. Sorry. No criticism. Well, she had, right. Oh, I thought you said she had twins.
Single embryos, sometimes they split and you still get twins. So that is a real risk, and that does happen. No, this time she had a single embryo. No, I wouldn't do that.
Could I ask a more basic question? Both of the speakers mentioned the multiple pregnancy rate with the use of clomiphene citrate, which is something that we have had handed down to us from when we start as medical students through to being trainees. My impression with the more modern approach to using clomiphene, where it isn't being, I don't know what it's like here, but certainly primary care providers no longer prescribe it. It's no longer used outside of quite close cycle monitoring, where you're looking and seeing if you're picking out those individuals who are uniquely sensitive and have multiple follicular development with clomiphene. My impression is that the multiple pregnancy rate is actually far lower than the often quoted 5 to 10%. I wonder if we're all relying on very, very old data from the old days, and it's not very interesting for somebody to revisit that and say, well, actually, what is the multiple pregnancy rate? Now we manage it in a more responsible and modern way. I'd just be interested in your comments on that.
Anybody else want to?
I didn't really get the question. You want to know the multiple pregnancy rate at concept here? Is that what you're asking?
No, I'm not asking for the rate. I'm just asking for a general comment as to whether or not we are guilty of repeatedly quoting the 5 to 10% multiple pregnancy rate with clomiphene, whereas in reality now it's actually not that high.
Yeah, I mean, it's certainly higher in Pakistan, because I can't give you the statistics because we're not very good at keeping statistics here, but we do see a lot of hyperstimulation, and that does indicate with clomiphene, okay, overdosing with that, and also using injectables, and this is not in IVF centers. So it's very poorly regulated and driven by, I don't know what, for the wrong reasons, perhaps. So we do see multiple pregnancies, clomiphene induced.
But we don't have statistics to tell you how much the percentage now.
Yeah. But then you see, they're not being monitored properly. Like, you know, are they doing follicle tracking? Unlikely. In IVF centers, yes, with transvaginal scan, in fact, in the other hall, we have an ongoing lecture on that. Unfortunately, it's not very well monitored. So we're not really at that stage yet to give you real solid statistics about it. Yeah.
Just two more comments. One's about multiple pregnancy and cervical shortening. You still have the option of progesterone though. So don't forget, if it's not staged.
Prophylaxis
You have,
preterm.
no, once you've got the shortening, you still have the option. If it's asymptomatic and just you notice it on scan, you've still got the option of progesterone for short cervical length, even if it's twin pregnancy. That's my impression.
For
I don't know about
how long you will suggest continue to prevent preterm labor? Something like utrogeston for long term?
Yes, you do give it till 30. If you can take her up to 36 weeks, you do give it.
Just prophylactically.
This is for the short cervical length on ultrasound.
Yeah.
Asymptomatic.
That's what we're talking about.
Yes.
Multiple pregnancy.
Yes. If you haven't got the option of stitch, but you've got the option of progesterone support, because there is a role of progesterone in short cervical length, irrespective of multiple or singleton gestation.
But for how long?
But that's what I'm saying. You give it till 36, till
We have guidelines by the RCOG for patients who are at high risk of preterm labor to give them prophylaxis for preterm labor, and that is to start progesterones from 20 weeks of gestation going on till 34 weeks. So they play a significant role in prevention of preterm labor. But if we come to the cerclage, if the patient is in preterm labor and having contractions, then there is no role for a cerclage. These are our experience for rescue cerclage is mostly with patients who come to us in the second trimester. They haven't been screened before in the first trimester for cervical incompetence, and then during the second trimester, based on their history and findings, you realize that there is cervical incompetence, but if they are in labor, then tocolysis is the way to go, not going for a cerclage. So patients for high risk of preterm labor should be selected on basis of their history in the beginning, and prophylaxis with progesterone can be used in these patients.
So thank you, Dr. Uzma. And this, going back to the first presentation by Dr. Samira, thank you very much for your presentation. It's just a comment I'd like to make, because we are dealing with women above 35, and in our infertility setup, there is no serum screening available in Lahore, at least where I practice. So we tend to offer only knuckle translucency mainly, especially to twins. We do have an IPT available now in Lahore, and it's costing around 60,000. So it's when you take the risks and benefits, I do offer it to my patients when there is increased age-related risk. So I do say that there is this option of an IPT available. Obviously I'm not doing it in twins, but I am doing it in singletons, because there is no other serum screening available.
Just a comment on this, for antenatal screening. The biochemical screening that Maria was just mentioning is available in Lahore, but only with the Aga Khan lab, and it is available as the triple test. They, I don't think, have added inhibin to it. So at 16 weeks, they would do biochemical screening for us. In terms of the NT scan, I just want to clear one misconception, that it is a screening test which should actually be offered to all patients. It is not for selected patients. Number two, just measuring the NT thickness is not an NT scan, or even checking the nasal bone, which is what is done by most sonologists in Lahore. It has to be linked with a computerized software report giving you a risk scoring. Only then it has any relevance. And based on these screening tests, then we would decide whether we need to go for any invasive testing. And in terms of the NIPT, which is, as Maria said, now available in Lahore as the Harmony test or Nifty test, it's very expensive. So one has to balance whether the patient can afford it and where it is indicated. But the major advantage is that it does not require any invasive testing. The sensitivity is 99% plus. So, but the cost is the limiting factor in that.
So thank you very much all my panelists, Dr. Azra Nasreen, Dr. Razia Ahmed and Dr. Fouzia Monoo, and my chairpersons, Dr. Kevin and Dr. Maria. Our session's time ends here, and I would like to invite Dr. Uzma Akram to moderate the next session. Thank you very much.